So welcome and good morning, everyone. We want to welcome you to today's Hastings Conversation, Public Trust in Science. We plan to spend the next 45 minutes delving into how we can better build public trust and manage the COVID-19 pandemic. To help us think through these enormous challenges, we're really privileged to be joined by Dr. Anthony Fauci, who will be in conversation with Hastings Center President, Dr. Mildred Solomon. We want you, our audience, to engage as much as possible with today's topic and our guest. So please ask your questions as you have them by typing them into the Q&A box at the bottom of your screen. Some of you may have the option to raise your virtual hand, but please note we will only be taking questions through the Q&A. The discussants will pause a bit before the end of the session in order to address some of your questions. If you have a comment or if your question doesn't get answered, I'd encourage you to continue the conversation on Twitter using the hashtag #PublicTrustScience. Dr. Solomon will be responding to tweets after the event using her handle @MildredZ Solomon. A recorded version of today's webinar will be available on the Hastings Center's website later today, where you can also find recordings of our previous webinars. And now it's my pleasure to introduce Mildred Solomon, who will be leading today's discussion.
Hello, everybody. It's my great pleasure to welcome you to today's Hastings Conversation, Public Trust in Science. Before we begin, I'd like to thank the John S. and James L. Knight Foundation and the Gil Omen and Martha Darling Initiative for Trusted and Trustworthy Scientific Innovation. Both donors have provided generous support for this event. We are meeting at a perilous moment in our nation's history. A pandemic out of control, and a highly polarized public, unwilling or unable to coalesce in unified action. And yet, at the same time, it's a moment of unprecedented opportunity. We have news of promising therapeutics and vaccines. It's also a moment of greater recognition of longstanding health inequities, which have been made inescapably visible by the pandemic. And in turn, that has created new possibilities for health justice and racial reckoning. So peril and opportunity. To many of us at the Hastings Center, it seems that whichever route we go toward the perilous or toward the opportunities, trust and trustworthiness are going to be determinative. Trustworthiness of the scientific enterprise, trust of scientific expertise, and trust in each other. So as we thought about what would be most compelling for our next Hastings conversation, we could think of nothing more important than the problems of trust and trustworthiness. And to help us unpack these challenges, our guest today is Dr. Anthony Fauci, the head of the National Institute of Allergy and Infectious Diseases at the National Institutes of Health. Dr. Fauci needs no introduction. He is one of the most well-known, most impactful, and most trusted scientific authorities in the nation. He's advised 6 presidents on many domestic and global health issues, including other viral pandemics like Ebola and Zika. But I wanted to start by drawing attention to his leadership in President George W. Bush's Emergency Plan for AIDS Relief, or as it's known, the PEPFAR program, which saved millions of lives around the world. I bring up PEPFAR and HIV/AIDS because that too was a period when society was grappling with how to handle a new and frightening disease. Dr. Fauci brought calm to the public square, and he built trust between gay community activists and scientists so that eventually they could work together very effectively. That's just one example of the many, many ways in which Dr. Fauci has been building public trust in science over the course of his illustrious career. So welcome, Dr. Fauci, and thank you very much for agreeing to participate today. You've honored the Hastings Center.
Right. Thank you very much for having me. I really appreciate it. Look forward to our conversation.
I'd like to start by asking you to reflect on the way I just framed this moment. Do you see it as filled with both peril and opportunity?
Oh, absolutely. I think you hit the nail right on the head, Dr. Solomon. It is unprecedented peril, at least when you look back over 102 years. We've had a number of outbreaks. You mentioned HIV, which has some similarities, but is fundamentally very different in the chronicity of it, how it started off in a very insidious way the stigma in the early years, the things that we had to do to reach out to activists who, quite frankly, were correct in their demands, which were justifiable demands of being heard when the rather rigid scientific and regulatory community were not paying attention to them. But what we're dealing with now is just an explosive pandemic, like I mentioned, the likes of which we have not seen with regard to pandemics and respiratory-borne illnesses in 102 years since the 1918 pandemic. It is occurring, and I'm sure we'll get into this in discussion shortly. It is unique in its magnitude and its impact, but it's also occurring at the most inopportune time, if you can say that, when there is extraordinary divisiveness in society, political polarization, where something that has occurred that is fundamentally detrimental to a public health agenda, and that is the politicization and the divisiveness of a public health issue. And I must say, as you mentioned, I've served 6 administrations, and I've been doing this as the director of the Institute for 36 years. And I've never seen a situation in which a public health issue has been thrust into divisiveness, where things as simple as public health measures, like wearing a mask, avoiding close contact, not congregating indoors, has taken on a situation where the pushback against it has a political and ideological connotation to it. You cannot properly and successfully implement a public health program when you have that much of a disagreement in society, because infectious diseases don't distinguish between one's ideology. It's really an example of we are all in this together, regardless of where you're coming from, what your thoughts are, what your ideology is. We all have to be in this together. That's the challenge. The opportunity, as you mentioned, I can look at it as 2 opportunities, just very briefly. One is the scientific opportunity, and the other is the opportunity to shed light on inequities in society that have been there forever, that maybe the accentuation of that in the context of COVID might make us get committed in the future to address it a little bit more seriously. So the scientific opportunities you just alluded to, just in the last 2 weeks, we've had an extraordinary advance in a highly, highly efficacious vaccines. 2 of them out of the 6 that the federal government is strongly backing and supporting, both in the development and the implementation of the vaccine trials. We've had a 95% efficacy of 2 trials. I mean, I could tell you, I'm a realist, but I'm also a cautious optimist. And I had thought that 75% efficacy would have been that I would have gladly taken. And now we have a situation where we have a 95% efficacy, and there'll be more to come because there'll be other vaccines that hopefully will have a similar. So that's the scientific opportunity. The social opportunity that I think is really important is that here again, but it's even more amplified, we have a situation of health disparities among minority populations, particularly African American and Latinx, also Native Americans and Alaskan Natives and Pacific Islanders, where it's a 2-fold disparity. One, the very nature of the jobs that most of these people have. I mean, you don't like to generalize, but I think here generalization is informative, where they're outside in critical jobs in society that put them into contact with people during the time of a respiratory-borne outbreak. So their chances of their getting infected are far greater than you and I sitting in front of a computer safely talking to each other. The other thing is that the underlying comorbidities that they have, namely the diabetes, obesity, hypertension, chronic lung disease, kidney disease, puts them at a significantly higher risk of not only hospitalization, but even death. That is not a racial issue. That is a social determinants of health issue. That goes back, as we've said, from the time that they were born, when the environment in which you grow up in, the diet you're exposed to, that leads to the kinds of diseases that we're seeing as comorbidities that are putting them at a higher risk. So if anything comes out of this when we get out of this, Dr. Solomon, anything that is telling us to say, wait a minute, let's take a look at this, it should be a firm, decade-long commitment to doing something about these social determinants of health. Because if we don't, they're not going to spontaneously go away. And the next time we have an outbreak, it's going to be the same thing. Sorry, I went on a little bit too long.
Absolutely, absolutely wonderful. I couldn't agree with you more about the opportunities here, the social opportunities to finally address health inequities. The pandemic has just made them so egregiously visible that we have to take action. And I know at the Hastings Center, we're doing a number of things to try to ensure that both as an organization, but bioethics as a field can broaden its lens to look at more structural issues that create really intractable inequities at the population level, economically, in the whole way we organize ourselves socially. So thank you so much for bringing all that forward. You've touched on many things that I had prepared questions for. So maybe we can come back to them in various different orders. It is extraordinary that we're seeing 90 or 95% effectiveness in several of these vaccines, but could you unpack that for me a little? I understand that effectiveness means that 90 to 95% of people will be protected from serious illness, from symptoms, and perhaps from getting seriously ill or dying, which is a fantastic thing, a real breakthrough, but that we don't know yet whether the vaccines will protect against infection. Right. And I think that might implicate some trust issues if people think wrongly that they are protected from affecting other people when they go to visit grandma. Perhaps we're not ready there to say right. that. Do I have the facts straight? And then if I do, how can we ward that potential problem off?
You have passed the exam with a mark of 91%. You're 9%, not wrong, but I need to fine tune it. So,
okay, good.
So let me explain. So the two vaccine trials that were completed, and we have the results on now, are the Moderna trial and the Pfizer trial that are using a platform called messenger RNA. Okay. The primary endpoint of the trial was clinically apparent disease. It could be mild to moderate. The secondary endpoint was infection or severe disease. Now that's important. That's what the 8% that you didn't get completely correct, okay. but everything else was right on. So the 95%, and I want to just, for the audience, just use some fine tuning of terminology. Efficacy is the result of a trial under the appropriate controlled conditions. Effectiveness is how the vaccine impacts the population that you ultimately want to impact. So we have a highly, highly efficacious vaccines, plural. How effective they will be on society will be determined by a number of factors, including how many people decide they want to get vaccinated. So if you have a 95% efficacious vaccine and only 50% of the people want to get vaccinated, that's not going to be a very effective tool. So that's what we have there. But now with regard to the question you asked about serious disease. So the endpoints that were primary determined the percent, 95% in both. One was 94.5, one was 95. They're the same thing. In the study of Pfizer, what they had was 10 severe events. One of them was in the vaccine and 9 of them was in the placebo. In the Moderna study, they had 11 severe events, 11 of them in the placebo, 0 in the vaccine. So we do know two things, that it's efficacious in preventing infection that is clinically recognizable, and it also is effective in preventing severe disease. What we don't know yet is whether it's effective in preventing infection. In other words, am I a person who was infected, but I didn't get symptoms?
Right.
I count as a plus for the vaccine, but I'm still infected. Now, the question that we don't know, Dr. Solomon, which is going to be really interesting, if I'm infected but was vaccinated, is the level of virus going to be so low in me because even though I got infected, the immune response dampened the level of virus so that I'm not going to be infecting other people? That we don't know. We know that if you completely eliminate the virus, you're not going to infect anybody else. So the open question is, since we don't know how well yet it prevents infection, what impact is it going to have on transmission? That's the open question in the discussion.
You know, one part of trust has to do with full disclosure and transparency in communication. So how should we be explaining what you just said, both to people when they get the vaccine? I've been having a sort of fantasy dialogue in my mind of what it might be, like letting people know that this is great, it's going to protect you, but we don't yet know if you might still be able to infect others.
Right.
Do you think that is, and then there might also be a population level public communication campaign in general.
Yeah.
So there's two levels there. What I'm worried because I'm hearing people say that the vaccine prevents disease when, it does prevent symptomatic disease. How should we be gearing up now to develop a really wise communication strategy?
Yeah, you know, we can borrow. Influenza is not nearly as influenza vaccine is not nearly as effective as these two vaccines.
Oh, wow.
It's between 40 and 55%. So that's, in fact, that's a different story, but that's one of the reasons why there's some hesitancy of people taking influenza, because most people say it isn't a very good vaccine. But in many respects, it prevents serious illness, it prevents hospitalizations. We have the same issue with influenza. You can get vaccinated for influenza and you won't get sick, but it won't necessarily prevent you from actually getting infected. Mm-hmm. Only you won't know you're infected because you'll either get mild or no symptoms. So the way you want to communicate is the vaccine that you're getting is to prevent you from getting COVID disease. That is the communication fact. So if I get vaccinated, the vaccine will be successful in me because I'm not going to get sick. It's going to prevent me from getting mild symptoms and it's going to prevent me from getting severe disease. That's the communication. The issue that you're not completely protected against a degree of infection that you might even notice that you might be able to spread to others, which is the reason why the message that you may have heard me say now over the last couple of weeks on the media is that getting vaccinated with a highly efficacious vaccine does not mean that you're going to completely abandon public health measures, because it's conceivable that even though you're feeling fine with no symptoms, that you still have virus in you. So you've got to make sure, remember, the primary reason for wearing a mask is to prevent you from infecting others. You can get some benefit of blocking others infecting you, but the primary rationale is that you don't want someone who has no symptoms but is infected, infecting someone else. So I would think, and I don't want people to get the wrong idea, the public health measures, the stringency of it that we are under now can be dramatically reduced as more and more of the population gets vaccinated and there's more of a veil of protection in the community. But you don't want to abandon public health measures completely until, and this is important, until the level of virus in the community is so low that the risk to someone getting infected is minuscule. Then you could really be pulling back.
Now, I've heard you estimate that we're going to need as many as 70 or 80% of the population to be vaccinated,
right,
before we reach herd immunity.
Right.
And as you mentioned in your opening remarks, there's a large number of people who say they wouldn't trust a vaccine. Right. And what's difficult from a communications point of view is that their reasons for distrust are not all the same. Some
Right.
are hesitant to take any vaccine, and some are concerned that the research oversight process has been politicized and they're not trusting our regulatory institutions.
Right.
The state of New York's independent, the state of New York and the National Black Physicians Group have independently of one another, as I'm sure you well know, that they're going to do their own testing of vaccines. So what do we do to ensure that the system is trustworthy and that it's perceived as trustworthy?
Okay, so let's make sure that the audience doesn't get a misperception.
Okay, good.
New York.
We're at 91% there on that one.
No, you're good. You're at 96 now. You're getting there. So actually, those other groups in New York are not going to do their own testing.
Oh,
They're
I
gonna do
misspoke.
their own evaluation of the
Right, I
data.
misspoke. Yes.
They're going to do their own evaluation of the data. So, I think, Dr. Solomon, you hit on something really critical, because one has to look at what are the reasons people don't want to get vaccinated. If the reason is they believe that the process was either opaque or slippery, namely some political person is going to want to get a vaccine out quickly or what have you, what decision is made behind closed doors? Is this really safe? It's so quick. What do you mean it's so fast? You told me 5 years ago that it takes years to get a vaccine, and now you're telling me you have a safe and efficacious vaccine within less than a year. What's going on here? So what we need to do is, in a very clear, understandable way, explain, and I try to do this as often as I possibly can, to the general public, that the speed itself is a reflection of scientific advances. In other words, the technology of making a vaccine is not your grandfather's technology. It's the 21st century technology. It's taking a virus that you don't even have to grow up or purify. You just need the genetic sequence. You pull the gene out, you stick it into a vaccine platform, and literally within days, you're making a vaccine. Already, you saved maybe a year there. Then you get that technology and you quickly develop it, because that technology isn't the kind that requires growing of the virus. You save another multiple months. Now you're in a phase 1 trial. So that speed, people hear speed and they say, wow, that's compromising safety. It has nothing to do with safety yet, because you haven't even put it into a person. So the speed has to do with the really exquisite technology. Then the other aspect of the speed is that the federal government has invested billions of dollars at risk. And the risk is not to the person, the risk is to the money. Because what they've done is they've started producing doses of vaccine before you even know it works. So that if the vaccine works, which by the way, it does, you have saved months and months. If it doesn't work, which is not an issue now, then you've lost $1 billion. So the government felt that the risk of the benefit of getting it quickly is worth the risk to the money. So that's what you got to explain. This speed has nothing to do with compromising safety or compromising scientific integrity. Then the next thing is, what about the process of deciding if it works or not? Is it some bunch of people behind a smoke-filled room making that decision? No, it's an independent body of a data safety and monitoring board that is beholden to no one, not to the president, not to the company. They're independent. They're the ones that evaluate the data. When they evaluate it, then they present it to me and the company and one of the other government agencies. We look at it, then the company presents it to the FDA with career scientists there who are beholden to no one. And then there's an independent advisory committee called VRPAC, or the Vaccines and Related Biological Products Advisory Committee. They independently evaluate it. So by the time you get the FDA deeming that this is a safe and efficacious vaccine, you've had an independent and transparent process decide. we've got to keep hammering that home, because for the group of people who are concerned about the process is sound. However, there's another group of people who don't even believe that this is a phenomenon, like they think it's fake news. That's where I have a big difficulty in how I'm going to get to that group of people. They actually don't think that this is a problem, despite 250,000 deaths, despite more than 11 million infections, despite 150,000 new infections a day. They don't believe it's real. That is a real problem.
Absolutely. And we would need another hour to go to explore that in days. But there's one aspect to that that I want to bring up, and then we are going to open it to the group. You've just given a really important background on why we should trust these astoundingly efficacious vaccines. This is really good news. But you've also said that it's important that we continue to wear masks and social distance, particularly until we learn more about whether we're still contagious with the vaccine or not. Many people who are opposed to mask wearing and social distancing are invoking a liberty argument. They're asserting that public health policymakers are unduly restricting their freedom. I think you would agree with me that that's a problematic narrative. They like to invoke, I've seen signs holding up Thomas Jefferson, but of course our founders were basing their beliefs on 18th century political philosophers like John Locke, who said very explicitly that liberty is not the same as license. How do we get that message across?
Yeah, I mean, I think the message is going to be, you can make analogies to something they understand. They don't want any encroachment on their liberties. So what about seatbelts? What does that mean? They accept that. Yeah. I mean, I mean, to me, there's a typical example right there. I mean, seatbelts. What about speed limits? Are you really allowed to go as fast as you want to go because I don't really care? Because if I get hurt, that's my problem? No, because you might hurt somebody else. The same thing with infection. I don't really care. I mean, and that's an important thing, because a lot of the attitude is, for those who even believe there is infection, to say the vast majority of people, particularly young people, they're going to get infected. They're not going to get any symptoms. What do I care? Well, you should care, because it might not impact you, but if you get infected because you're careless in protecting yourself, not only are you making a mistake personally, because you could get seriously ill, even though you think you're completely protected, then you are propagating an outbreak, because you are allowing the virus to continue to propagate through society. So there is a societal responsibility in protecting yourself from getting infected, because if you don't, you are propagating the outbreak, and you might inadvertently and innocently, I don't even want to be pejorative about it, you're going to be innocently infecting someone else who might infect someone else, who then all of a sudden you have an elderly person, somebody on chemotherapy, who is going to get seriously ill. So this narrative that this is my business, if I get infected, I don't care because I'm willing to take the risk. If you mine down on that, you see that it's more complicated than that, because you're getting infected means you're part of the problem, not part of the solution.
It harms other people, and we need to care about that. And it also reflects a uber individualism that is really wrong-headed. Human beings don't get very far without social connections and collaboration. We need each other, and our well-being depends not only on our personal freedom, but also on the support and care that we give each other. But I think we have our work ahead of us to try to develop that narrative in a way that respects everybody's starting point and doesn't shame people, given or other people, no matter what their views are. It's a big, tall order. We're going to have to pause now because I know there's a lot of questions out there. I asked Isabel to go through them and choose one or two to pass on to us. And then I'm going to come back with a final question or two for Dr. Fauci.
Hi there. Yeah, we've had so many excellent questions, so thank you for sending them. It's hard to know where to start. But I guess one question is that we have several chaplains and health and kind of religious health leaders on the call. And some of those folks are wondering kind of what is the role of faith centers and faith leaders in kind of talking about science, ensuring trust in science, and how can faith centers become spaces of health promotion? Some of our commenters have specifically referenced that many minority communities deeply trust their religious leaders. So they're just curious, kind of, Dr. Fauci, your perspective on what role those communities can have and scientists with those communities.
Well, I do have a now decades experienced opinion of that. You know, most of people knew me before COVID because of my decades-long work with HIV. And I could tell you, faith-based communities, religious organizations, churches have played a major positive role in our response to HIV/AIDS pandemic, both domestically and internationally, in getting people to appreciate the importance of getting tested, of the importance of getting into treatment when you're infected, and the importance of prophylaxis to prepare and prevent yourself from getting infected. In fact, the PEPFAR movement that I played a role in with President George W. Bush to put that together with his vision of getting that was very much supported by the faith-based community. So I think if we can galvanize the faith-based community to get people to understand the seriousness of this outbreak and why it's part of everyone's problem and we've all got to pull together, wow, I'm all for that. And, you know, just count me in on that.
Isabel, do you have another question?
Yeah, absolutely. So we have a special question coming from a science teacher who participated in a Hastings Center workshop. And she teaches, I think, in a primary or secondary school, and is curious, Dr. Fauci, what advice do you have for K through 12 teachers who are striving to prepare the next generation to enter into this complicated world of understanding facts, where culture, politics, emotions, and any other number of factors are at play? How can those teachers best prepare young folks in this world?
Well, I mean, I think the earlier you start in getting people to understand the importance of honesty and transparency and making decisions, whatever level of your age, based on evidence and data. Now, maybe somebody early on in the K through 12 process doesn't process that in their mind, but I think you could get them to understand you make a decision based on information, and you try as best as you can to validate that that information is correct. And I think if we start training children in that age range to be asking questions, to be not afraid to say, I do not know, and to try and gain data and evidence to inform your decisions. To me, there's no age that's too young to start that with. So that's what I think that the teachers in that group should try and teach the students.
Isabel?
Great. Yeah, so we have a bit of, we have a couple other questions that we could ask. One is, so we have some audience members who are coming in from Mexico, from Brazil, from all of these different countries, including in Europe. And a kind of a common theme has been, how should global governments, so not just the United States, how should other governments who maybe have had missteps, as we all have in our handling of the pandemic, how can they recover trust from their citizens, from their population, with an eye to encouraging folks to take a vaccine, but also kind of as a general reminder of trust in science? How can that process of healing and recovery help?
Well, healing and recovery, when you've made missteps, starts off by a realization and admitting that you've made a misstep. I think if people look back in the history of outbreaks, it never goes smoothly. So if you've made a misstep, that's an honest misstep, that admitting it and saying we're going to course correct is really part of the history of successful addressing of outbreaks. I mean, there's never been a serious outbreak in which everything was absolutely smooth going through it. You know, you have to think, if you like to talk in terms of metaphors, it's really like a war. You know, if you talk to generals, which I have the opportunity now as a person in government, they tell you whenever you go into a war, there's a plan. And then as soon as the war starts, there becomes the fog of war that they talk about. I can tell you, when you're fighting an outbreak that you have had no prior experience with, there's a lot of fog there. And in the fog, there will be missteps. So what you need to do to be humble enough and honest enough to know that you learn for those mistakes and you go on. When the citizenry in your country, wherever you are, in Africa or Asia or the United States or wherever, realize that you are now moving forward with the best available information, you will be forgiven for the missteps, so long as you're honest about it.
That's great. Millie, do we have time for one more? Or shall we keep going?
Yes, we do, if brief, because I have a couple of questions I'd like to end with, but please do.
So the final question that keeps coming up throughout this entire session, you spent, some time talking and kind of parsing the vaccine process, why this vaccine approval process is different than it has been in the past. But there are still kind of remaining residual questions among many folks about how do we know how to think about long-term safety or health implications from the vaccine? What can you kind of share with our audience that can either kind of help them think about it and help communicate with family members and friends who are vaccine hesitant because of unknown long-term effects?
That's an excellent question. So one of the things you do is you start with the history of vaccinology. And if you look at vaccines from their decades and decades and decades long history, in fact, it's even centuries if you go back to smallpox, but the history of vaccines is that they are remarkably safe, particularly in the long run. When you do see adverse events, almost always they are relatively early recognizable. There are very few situations, in fact, I can't even name any, where you have something that way down the pike, namely years later, you have a long-term effect. So in general, the history of this particular endeavor is remarkable for its safety. The next thing is that there are long-term follow-ups. Although you get the results of these studies in a few months, the studies go on for a couple of years. And then there's the post-vaccine observation. So although you have to be honest, you can't 100% guarantee that there's not going to be a long-term effect. But history tells us it's extraordinarily unusual if that's going to happen. In fact, it would be unprecedented in some respects.
Great, thank you.
Thanks, Isabel, and thanks to everyone in the audience for proposing those questions. Dr. Fauci, another aspect of trust has to do with access to the benefits of new medicines and vaccines. Give us your best guess. Do you think that these promising therapeutics and vaccines are going to be accessible to all of us, regardless of ability to pay? Both of us in our earlier remarks talked about how there's been so much greater burden on communities of color and on the poor. So what's your sense of accessibility at the end of the day?
Okay. Well, let's take pay. This is going to be free. The government's paying for this. You're not going to pay for the vaccine. I mean, there may be a charge for the administration, but I'm hearing, and this is not my responsibility, but I'm hearing that the government organizations, Medicaid and Medicare, are going to be able to handle that. So this should not be a financial issue. The question is access beyond financial. So the way this works is that ultimately and traditionally, the CDC, the Centers for Disease Control and Prevention, have the responsibility for determining the prioritization of who gets it first when you have a limited amount early on and you continue over months to get more and more. It's a prioritization list, like who's going to be first, second, third, fourth. That is informed to them from an advisory committee on immunization practices, the ACIP. because of the seriousness of the situation, an extra layer has been added in the advice from the National Academy of Medicine. So now you have both of those organizations feeding into the CDC that will make a prioritization. That prioritization is going to be made public and people will understand it. What we must be committed to doing, that even though there's a prioritization, is to make sure that when vaccine is available, that it actually gets to the people on that priority list. Because just by putting them on a priority list doesn't mean they're all of a sudden automatically going to get it. So we need to make sure we pay attention to that and get it distributed, for example, to those areas, to those clinics where you do have a demographic group that is of a priority that they should be getting the vaccine. And that includes, as I mentioned early on, a minority population, or African American and Latinx, who have a higher chance of getting infected and a higher chance of getting an adverse event from the virus, not from the vaccine, right?
And finally, you're one of the most trusted science experts in the country. What do you think accounts for that? Like, what's in your behavior or in your way of being that has built trust?
Well, I guess that's for others to decide, but I think, you know, I tell you what I try to do, Dr. Solomon. You know, I'm not sure I'm always successful, but I try very hard to do what I've just given some of the advice, for example, to the teachers. I try to base everything I do on solid data and solid evidence, number one. Number two, I'm very transparent and I'm consistent. Number three, I don't have any ideology or any political issues. I am an apolitical person completely. I'm a scientist and a public health service. And the other thing is that I admit when I don't know something. And one of the things people get into trouble with is if they start talking about things and they don't either say, by the way, I can tell you this, but I'm not sure because I don't have the data on it. I think you have to be humble enough to realize that you can't know everything. And when someone asks you something and you don't know it, don't be afraid to say, I do not know.
Do you think that scientists in general have responsibilities to communicate with the public? And if they do, should we be incentivizing training for everyone in our PhD programs?
Oh, I mean, I think scientists do have a responsibility. As you know, it's not something that is equally distributed among scientists and their ability to do that. But I think many of us in the scientific community can continue to learn not only that it is our responsibility, but that it's something that we need to learn how to do that. I have found one of the things that when my fellows and students ask me about communication, you know, what's the hint? What's one or two things that you would want to tell them? And I always say it's, you know, a precision of thought and economy of expression. Less is best. Sometimes people tend to go on and then all of a sudden you start seeing eyes glaze over. The other thing, you know, that I really think is important, and scientists sometimes innocently and inadvertently fall into this. You've got to know your audience and you've got to make sure that you have a crisp, clear message. Sometimes when you see scientists, they think they're speaking to the National Academy of Science and they're speaking to the general lay public, or they're speaking to the National Academy of Sciences and they act like they're speaking to the general. You got to know who your audience is. That's absolutely very important. And then the final thing I tell them is that when you're a scientist and you get up and talking to a general audience, the important goal is not to impress them about how smart you are. The important goal is for them to understand what the heck you're talking about. And very often when scientists get up, they get very detailed and they lose the audience. And that's one of the reasons why I think in many respects, scientists can do better. You don't want to lose your audience. You want to stay connected with your audience.
Well, on the theory that less is best, I have a 2-word way to end this. Thank you. This was really fantastic. Thanks so very much.
Thank you very much, Dr. Solomon.
And thank you for everything you're doing around the country. We really need you. Thank you.
Thank you. Good to be with you.
With that being said, I just want to thank everyone for joining us today. As a reminder, this conversation is recorded and it will be available on the Hastings Center's website later today. You can also continue the conversation on Twitter using the hashtag #PublicTrustScience. Thank you, everyone.